Hi, everyone. Thank you so much for joining our training. We're going to give it a second or so as people are trickling in. Okay. Welcome everybody to our third training in our implicit bias series. Today's training topic is serving people experiencing houselessness with complex healthcare needs. And the training co-presenters with me here are Julie Silas and Carla Carvalho, and they are part of the home-based healthcare team, and they are very excited to talk about this really important topic. So without further ado, I'll pass it to Carla.
Thanks so much, Sarah. Thank you all so much for being here. I know it's a Friday afternoon after lunch too, or during lunch. So I know that can be sort of a time that folks might be tired from the week or just sort of winding down from the week. So hope to make this training as helpful to you all as possible. And hopefully it'll give you a little energy, or at least we can bring the energy to kind of offset that Friday afternoon feeling. So yeah, thank you so much for being here. And like Sarah said, my name is Carla Carvalho. I'm a policy analyst at Homebase, and I'm joined by my colleague Julie, who I'll let her introduce herself right now.
Hi all, welcome. I'm Julie Silas. I'm a senior directing attorney at Homebase and do a lot of work at the cross sector of healthcare and homelessness. Glad to see you all.
Thanks, Julie. So yeah, like Julie said, both of us have been working on healthcare and homelessness, sort of that intersection at Homebase. And so we're really glad to be here today to talk about serving people experiencing homelessness or houselessness, whichever term that your community or you use, with complex healthcare needs. So during this training, oh, and also wanted to say too, Julie and I are totally okay with being interrupted, especially if there's any points of clarification, any acronyms that we use that maybe you're not familiar with, anything that just was unclear. We'd really like for you to be able to ask those questions and interact with us. So please feel free to pop your question in the chat. Sarah's going to keep an eye on it, and then whoever's not talking will also keep an eye on it. Or you can raise your Zoom hand, come off mute. Just let us know if you would like to ask a question. Yeah, there's going to be a little bit of interactivity, but we'll talk a little bit more about that. So during this training, you will hear about the basic healthcare resources that are available for the folks that you're serving or for folks experiencing homelessness in your community. You're going to consider what you learned can actually be used in your community and in your organization and for your clients. And then hopefully you'll be better equipped with the tools, the resources, and the knowledge to just be able to connect the people that you serve with the healthcare coverage and the housing related services that can be covered by healthcare programs to better connect your clients to resources. So just to preview today's agenda so you know what to expect. So first, we're going to kind of just set the context, probably things that you all are very familiar with in your experience in serving folks who are unhoused or experiencing housing instability. And then we're going to talk about Medi-Cal and sort of the 101 on Medi-Cal. We're going to then cover CalAIM and those new housing related services. And then since this is sort of a longer training, we're going to offer a break in there. And then we'll move on to the Medi-Cal unwinding or Medi-Cal renewals that is happening. And then healthcare delivery, other resources for folks who are experiencing homelessness to access healthcare. So first, we're going to begin on setting the context. How and why experiencing homelessness impacts health. So let me move on to the next slide. So first, we'd like to start with a reflection just to like kind of ground folks and get your brain sort of moving in this direction. So if you have a piece of paper and a pen, this would be great, or you can type out your answer to yourself in like a Word document or something on your computer. But we'd like for you to reflect for 2 minutes on how does homelessness impact health? So how does homelessness impact health? And you don't need to share it in the chat or come off mute or anything just yet. Just kind of think about that and maybe write down your answer. So I'll wait until 1:10. One more minute. Awesome. Perfect. So now, so you wrote down how does homelessness impact health? So now we're gonna just kind of move folks into a quick breakout room. You'll be in there for about 2 to 3 minutes. Sorry, for 4 minutes, and you'll introduce yourselves, your name and your organization, and then sort of share what you were reflecting on. So share your thoughts about the connections between homelessness and health. Julie, are those breakout rooms ready to go? Awesome. Go ahead. And if you have any issues getting into the breakout rooms, just please let us know.
Sarah, do you want to join Leslie? Maribel is not going in there yet, so Leslie's by themselves.
Bring folks back at like 1:13, 1:14.
Yeah. Gabrielle and Maribel, do you need to go? Do you all need us to move you to a room? It was just you. I'll put you in a different room.
Maybe I'll do till 1:14 or 1:15.
Yeah.
Okay.
I think let's see, do we have 2 people in every room?
Yeah, and folks are talking too.
Okay.
We got a new person coming in, so. Hi, Angelica. Welcome to this training. So folks are just in breakout rooms right now, just sort of sharing their thoughts about the connections between homelessness and health. If you want, we can move you into a breakout room. We still got about 3 minutes left.
You just have to,
Hi, sorry,
yeah,
I'm trying to enter to the room.
yeah, just, it should show on your screen that you can join room 2. I just reassigned you to room 2.
Okay, okay, perfect. Thank you. Going to
Thank you.
try to look for it. Oh, because I'm trying to answer, can you send it again?
Try it
So,
again, yeah,
thank you.
okay. Should work. There we go. How can you tell they're talking? Oh, the unmute.
Yeah, the unmute, which I really, it's a really good feature in Zoom.
Yes.
And I just broadcast a message saying like 2 more minutes, just so folks like know that
Yeah.
we're timing it, but
Yeah, and it takes a minute to call them back. So
yeah. Oh, that's a good point. So when you click close rooms, there's still going to be
a
that's
minute.
okay, though. Yeah, that's good.
Should I do that now?
Maybe at 1:15 just to
Okay, we have time. It's 2
Yeah.
hour meeting. We have time.
yeah. I was a little worried there for a second.
Folks in room 5 are not talking. Oh, now they are.
Oh, okay.
So they're more in groups of 3.
Yeah. Do we want to keep the same breakout rooms, or are you gonna like
I'm gonna do different, don't you think?
Yeah, I think
Yeah.
so too. Talk to different people.
Yeah.
I got like random compliments on my facilitation today from like different home basers, like at different meetings. And I'm like,
Yes.
because my brain is just, I talk so fast and people are like, no, you talk so conversationally and it's so nice to
Yes.
hear you talk. And I'm like, it's not nice in my brain. So
Yeah. It's confidence. If you have confidence, imagine how much even more
I know.
slamming it, home running it. All right, I'm gonna pull them back for that
Sounds
minute.
good. Perfect. Hi, y'all. We're just waiting for some folks to trickle back.
They're still chatting.
Yeah, folks are going to chat till the end. That's great.
The very last second. 10 more seconds.
Nice meeting you both.
Hi, y'all. Welcome back to the main room. We're just waiting for everybody to kind of come back in. I think everyone's back. And it's also nice to see some faces. So always happy if folks are able to and willing to, yeah, be on camera. It's always nice to see faces. Thank you all so much for participating in that. So now that we're all back together, does anyone want to either come off mute or even pop in the chat, like sort of what your group talked about, or even what your own thoughts or reflections were around this question about how does homelessness impact health?
Yeah, I sure will. So in my group, it was Keith and I, and we discussed the parallels between houselessness and health, and oftentimes doctors forming opinions that otherwise aren't accurate, and that being reasons to not give treatment. We also discussed that getting surgeries is likely not a possibility given that there's not typically a place to recover. We discussed that most times that these individuals will also be living a tremendous less amount of time than somebody who was housed.
Thank you so much, Georgia. Those were all very important points, and some of which we're going to talk about a little bit later. So thank you. Does anyone else want to offer what reflections or what the conversation was like in your group?
Hi, this is Emmeline from the Housing Authority. My group talked about how being outside, we were exposed to a lot of elements, and like the weather, when the weather changes, how that, even just all sorts of things, right? Like if you have an infection and you're not able to keep it clean, you don't have someone in the like who can always tend to it or help, redress it or anything like that, right? But also if they're in congregate shelter, you yourself could try to stay clean or just try to be as safe as you can, but you can't control the folks around you. And I've seen some of these shelters and how tight the space can be. So, just proximity, if somebody's not feeling well, it's hard to, it's challenging. But to kind of to resonate with what Georgia said, like because I'm in housing, I know we have folks who may be waiting to get a voucher or who have a voucher and they're prolonging getting surgery done because they need a place to recover after. So it's like it could be a surgery that they really need to get right now, but if it takes them a month to get better, they need to the timing of it can be really challenging. So
yeah. Thank you so much for that, because that also that sounds like it's not just a gap in San Mateo, it's a gap in many of the communities that we work in and many of the COCs and counties. But thanks for pointing that as like a very glaring, it sounds like, gap that you all see for the folks that you serve, and how homelessness impacts health, and how not having that space for the person to recover could really put them in sometimes even worse position, right? So thank you for sharing that, and thank you all for having those meaningful discussions. We just kind of wanted to start with that reflection just to sort of anchor us in what we're going to be talking about today and why we're talking about it. So really appreciate that. So this slide, homelessness and poor health. So these are actually, some of you actually touched on this a little bit. And so we know that you all are very familiar with the fact that folks experiencing homelessness, obviously have more contact, like Emmeline was saying, with folks who maybe have communicable diseases and infections just because of settings, congregate shelter being one of them, right? That was like a huge thing in the pandemic, right? And so that can happen. You all mentioned also like being exposed to extreme weather, malnutrition, and stress. Having a lack of running water to maintain cleanliness and refrigeration for medication storage, right, is a big thing. Folks have high rates of infectious and acute illnesses, so like skin diseases, tuberculosis, pneumonia, asthma, those chronic diseases like diabetes, hypertension, HIV/AIDS, cardiovascular disease, and some of those chronic diseases are the leading like killers of folks who are experiencing homelessness. And then poor mental health and or substance abuse and exposure to domestic violence. So all of those things, are obviously detrimental to a person's health. And then I don't remember if it was Emmeline who mentioned it, but the mortality rate is 3 to 4 times higher than for the general population, right? And we see that folks experiencing homelessness age a lot quicker than their housed counterparts, right? Because of that, just the general wear and tear of being on the streets, and then all the other things that are listed here, right? And so this isn't a comprehensive list, but just some of the things that you all are familiar with, and I'm just keeping in mind throughout this training. And then on top of like homelessness really negatively impacting a person's health and their life expectancy, folks experiencing homelessness often don't have information about what resources are even available to them or how to access those resources, right? don't always have access to behavioral health services. And we know, behavioral health services like substance use treatment and just like that crisis response, like those are very time sensitive things that folks don't often have access to when they really need it in that moment. And also just in general, just don't tend to have access to it in the long term sometimes. And then, of course, folks struggle with access to transportation or the ability to get to their appointments in the first place. And in some communities, that's more of a challenge than others, right? But it's always going to be a challenge for somebody who is unhoused. Also, an easy way to communicate with their providers, that can be a challenge if you don't have a phone, you don't have a mailing address, you are generally moving locations, for various reasons. Like it can be so hard, right, to communicate with your healthcare provider. Like I think about how I talk to my healthcare provider via an app on my phone. Like not everybody has access to that, right? And so that can be really challenging. And then, like I mentioned, like a home address to really receive that communication about healthcare benefits, about, the things that folks have access to and any changes in those benefits, which we'll talk about later. And then, on top of that, systems of care, like healthcare providers and the homeless system of care, are often not coordinated, right? That's starting to change in California. There's a lot of really great work happening all across the state to really like coordinate those systems and to integrate them, but it still continues to be a challenge. So what that means is that there's a lot of missing knowledge about people's history and their needs. There's a duplication of efforts, right, happening along both systems. There's a failure to connect people to what resources are available to them. And then eligible people are not consistently enrolled in benefits or engaged with healthcare resources. And without healthcare, it's challenging to achieve housing stability and well-being. So it just makes everything more challenging for folks. So one thing that Georgia and Keith sounds like they talked about was the impact of bias, right? And how healthcare providers, they're often not well, I guess, I don't know often, but are not knowledgeable necessarily about homelessness, its impact on folks, and sort of the unique challenges that folks experiencing homelessness face, right? And so that's where sort of bias can really come in. And so bias is the evaluation of one group and its members relative to another. And how does this bias impact what we're talking about, right? Bias can impact whether your client even receives services, which is something that Georgia mentioned, her and Keith talked about, and their experiences when they're accessing those services, right? And the reason that it's important to understand that is because you all as providers are, supporting and advocating for your clients as they access these services. And part of that is going to involve potentially supporting them through those experiences and being aware of these biases and these challenges that folks are going to face when they try to access services, right? So we're not going to spend too much time talking about bias, but we did want to kind of talk about the differences between explicit bias and implicit bias. So explicit bias is sort of that traditional conceptualization of bias that I think a lot of us have. It's sort of that overt racism, racist comments, sexism, positive or negative preferences for groups, and all of these biases are conscious when they're explicit, right? And so individuals, they're aware of their prejudices and their attitudes towards certain groups, versus implicit bias, which is also known as implicit prejudice or implicit attitude, is a negative attitude where someone's not consciously aware that they hold that attitude towards a group of people. It's thought to be shaped by the experience and based on learned associations between particular qualities and social categories, and that includes race or gender. So there's, racial bias, there's gender bias, and there's different types of biases. And where the problem comes in is like individuals' perceptions and their behaviors can impact the way that they treat somebody, right? Or the treatment that they offer somebody. So you think about a healthcare professional, right? And how can the bias that they hold impact the person that they're serving? So yeah, so that's kind of the differences there, right? The main difference being that explicit, the person is conscious that they're doing it. Implicit bias is that they're doing it but not consciously aware. And so here's some like examples of bias in healthcare. These are things that the San Mateo team shared with us that they've actually heard providers say either that their clients face or they've heard that clients have said this. So providers who don't take seriously people's pain and discomfort and concerns, right? That's one that's heard a lot. Healthcare providers believing that a person experiencing homelessness is actually exaggerating their illness to have a place to sleep or to be able to access certain resources. Providers who kind of perceive folks experiencing homelessness as lacking the capacity to care for themselves or don't want to change, don't want to grow, don't want to take charge of their lives. So it's like kind of their fault that they're going through all of this. So that kind of attitude. Staff saying things to clients like, I bet I'll see you back tomorrow, or you're wasting my time. Having biases about the root cause of an illness. And then misconceptions about the realities of what it is like to experience homelessness, right? Which ends up impacting the treatments that people receive, the medications that they're prescribed, and all of that. So there's real tangible impacts of that. And the reason we sort of wanted to, you notice we didn't assign these to say like implicit or explicit, because depending on whether the person who's like saying these things or doing these things, if they're consciously aware or not consciously aware of the bias that they're holding, will depend. A lot of these can be either or. So that's why we sort of kept that as just bias and not implicit or explicit. And then this is just like a resource we wanted to offer, the Harvard Implicit Association Test, and just to say like, implicit bias, we all have it, you know, as informed as individuals as we can be, as much as we care, and maybe a bias, that implicit bias that we hold does not line up with our values. All of us have implicit bias. And this test is actually really interesting if you've never taken it before, because it makes you like answer questions in rapid fire. And then at the end tells you like, oh, there's certain groups, here are the groups that maybe you have implicit bias against. And it's very eye-opening. And so we should check and be aware of our own implicit biases so that we can be conscious when it comes up in our brain, it's like, oh, challenging that. Like, why am I feeling? Here's like a moment where I'm like having implicit bias, and that's the only way that we can really kind of fight against this, right? And so this link will be linked on the PowerPoint slides when you get sent those, so you can access that test, or you can actually Google it too. All right, so I know I said a lot. Before we move into the next section, does anyone have any questions? I feel like a lot of this is like, you all are you know this very intimately, serving the folks that you do. So, but if you have any questions also, that's great too, or comments. Awesome. I will pass it to Julie to begin our next section then.
Thanks, Carla. I think our first thing we're going to do on healthcare coverage, if I'm not mistaken, is a Zoom poll. Is that right? Yeah. Okay. So we can go straight to the Zoom poll, and then Sarah, if you could turn the Zoom poll on. But before we start, we just wanted to gauge people's familiarity with the Medi-Cal program here and how familiar you are. So we're going to put up a Zoom poll and just ask you each to answer. You'll see we're just looking at the level of knowledge of Medi-Cal that you have, and that will help us how far we dig into things as we move forward. So what's your level of knowledge? I don't know much, but I'm excited to learn. I know a little bit, but like to know more. I help people enroll, but don't have much experience helping them access healthcare. And I'm pretty familiar with both accessing the program and applying for it. So let's get a good sense from you all where you're at. Give it another minute or two. Okay, I think we'll go ahead and end it now, and we'll show you all the results. It's a pretty good mix. All of you have some knowledge. about what's happening, a little bit about Medi-Cal, but there's the largest group who like to learn more. And so we're going to talk about it. I think the point of what I want to say is kind of reiterating what Carla said. As we go through this, we're going to try and figure out the right balance based on all your levels of experience. But if there are questions, please interrupt. You can put them in the chat, and Carla can interrupt me if you're not comfortable being an interrupter. But we really want to make sure as we move through this, you have as great and as a solid understanding. And for those of you who are really familiar with it, hopefully we dig in and we introduce you to some new things as we move through. So hopefully there will be some surprises for you, and then there will be some additional learning. So we'll go ahead and dive in. So just to say that we know that you all have some familiarity, but just saying out loud, Medicaid is a public health insurance program all across the country. It's jointly funded by the federal government and the state. It's governed by federal rules, regulations, and policy, but each state has its own definitions of eligibility, scope of services, providers, and payment rates. And so we often say, if you've seen one Medicaid program, you've seen one Medicaid program. It really varies all across the country. There are some basic things that apply no matter which part of the country you're in. That doesn't matter how they interpret it. They cannot deny or reduce coverage based on someone's pre-existing condition and illness or condition. They cover medically necessary services. So no matter what program you're in, what part of the country, services have to be medically necessary, and that beneficiaries have a choice of qualified providers. And in some situations, we'll talk about in a bit, sometimes that choice is limited, but there still is choice. And then in California, next slide, it's Medi-Cal. We call it Medi-Cal. And sometimes when I'm presenting, I will say Medicaid and I will say Medi-Cal. So for California purposes, I'm talking about the same program. So just be patient with me if you hear Medicaid. It's the same as Medi-Cal for California. Here we have almost 16 million people on Medi-Cal. It's administered by the California Department of Healthcare Services as a state agency, but at the local level, it's actually administered at your county. So San Mateo County administers the California Health Department's Medi-Cal services in San Mateo County. California's program is much more expansive than most other states, like hands down. And one of the biggest things just happened where now, as of January, so we're 2 months into it, a little over 2 months into it, Medi-Cal covers all California residents regardless of their immigration status. So we started out doing that with older adults and young folks under 26 years of age. And this year now, regardless of their age, everyone, regardless of their immigration status. And this is something that a lot of people didn't know happened. So you might or might not have been aware of it. And it's possible that the folks you work with who have, maybe they're 40 years old and they've lived here since they were 8, and they don't have DACA status, but they are not legally present in California. They may not realize, as they're experiencing homelessness, that they now can access healthcare when they couldn't if they tried last December. So this is a really important thing. Like, we talk about, like, most people who are in the homeless system of care should be on Medi-Cal or likely eligible for Medi-Cal. Suddenly, that number is probably a much higher number than it used to be. And I'm going to show you that slide in a minute. So that's just really something, if you are working with people with immigration status, not in California, not in the US, you should ask them if they have Medi-Cal, and if they don't, consider having them apply, because they may be eligible now when they weren't last year. And the other thing that's big, and Carla's going to go into it in detail in a little bit, is our Medi-Cal program now covers housing-related services as a medical benefit. A medically necessary benefit is housing deposits or housing navigation. So it's kind of a big fundamental shift. And it covers other non-medical supportive services that we aren't used to as well. But we're going to focus today on the housing ones. So it's really, really expansive and great opportunity to folks working on behalf of people experiencing homelessness try and use the healthcare system to ensure people have all that they need to keep healthy and be able to manage and stay in stable housing. People over income for Medi-Cal often have private insurance, but in California, there are significant subsidies through Covered California that people slightly above Medi-Cal eligibility, but even significantly above Medi-Cal eligibility, can still get the federal government to pay part of their premiums and lower their out-of-pocket costs. So when someone loses Medi-Cal, or when you find out someone's not eligible for Medi-Cal based on income, Covered California could possibly really provide pretty well subsidized coverage where it costs them very little to be fully insured. So that's something to just keep aware of. And if you have questions about that, we can answer those in a little bit. Okay, next slide. So this is the older slide that we always use, but some of these categories are changed a little bit. So it's 138% of poverty level or below for adults. And then for kids, there's a separate program called the Children's Health Insurance Program, or CHIP. And kids are eligible up to 250% of federal poverty level. So just keep that in mind. Their parents might not be eligible and they might be in Covered California, but their kids might still be eligible for Medi-Cal. It covers people with disabilities, older adults, people who are pregnant. It covers skilled nursing facility or intermediate care, parent or caretaker relative benefits, people who have been screened for breast or cervical cancer, and then it comes with a lot of other programs. So if you're on SSI, you automatically get Medi-Cal. And then some of these other programs, there's categorical eligibility, because the income levels are so similar that if you're eligible for this program, you're also eligible for that program. And I didn't say the refugee status for a limited time, because that one really is irrelevant now that regardless of immigration status, everyone gets Medi-Cal. So that's cool. That one no longer needs to be a special category. Next slide. So I talked about choice of providers, and in California, we have managed care, which limits a little bit of the choice of providers. And so I just wanted to kind of give some context. What traditional health insurance that you can just go to any provider you want is called fee-for-service Medicaid, in this case, or Medi-Cal. And basically you would go to someone, and if you're on Medi-Cal, they take your card and they bill Medi-Cal, and Medi-Cal pays them. So that's fee-for-service. And that was where the state contracts with providers to be a Medi-Cal provider, and the state pays them a fee. Managed care is an alternative to fee-for-service, where the state, it's kind of like the managed care plan becomes the intermediary, and the managed care plan gets paid by person by month, regardless of what services they use. And then the member gets their services through the Medicaid managed care plan. And so they receive a payment, like I said, per member per month. And I could use 0 services that month and they're still going to get paid. And Carla could have 2 hospitalizations and they're still going to get paid the same. And so the idea is that the managed care manages that risk. That's why it's called managing. And that there are some people who need a lot of care, some people who never use the care, and then it balances out to that per member per month. This becomes important with Medi-Cal, and especially when we talk about some of our other services. So it feels like you probably know about it, but it has implications when we move through some of these housing related benefits. Next slide. So California, we almost all, especially through Medi-Cal, have managed care plans. Each county has at least one. Some of them have more. Some plans operate in multiple counties. Kaiser Permanente is covered across the state. Anthem Blue Cross has many counties where they are provider managed care plan. And some counties like Sacramento has like five different managed care plans. What happens in Medi-Cal is that everyone is first enrolled in fee-for-service until they select or are put into a managed care plan. And most people when they're eligible, they select their managed care plan that's available in their county. Maybe it's 1 or 2, and they basically get the limited providers who are contracted with that managed care plan. And that's how it limits choice a little bit. They can't just go to any doctor or any nurse. It has to be one that's covered under that particular managed care plan. The weird thing, and Carla may talk about this when we talk about housing related services, is some of them are only provided by managed care plans. And so while the individual is in the fee for service piece, while they're selecting and choosing and the enrollment happens, they aren't eligible for some of those housing related services because they're only eligible through their managed care plan. So the soon as you can get your clients into an actual managed care plan, the quicker they will have access to the housing related services. And we can talk about that a little more when we get into those programs. Next slide. So how do you know your clients are on Medi-Cal? How do you know if you need to help them apply? How do you know what managed care plan they're in? So this is a statistic that we know prior to this new rule about immigration status, where about 70% or more of people experiencing homelessness are eligible for Medi-Cal. That doesn't mean they're actually signed up and enrolled, but they're eligible based on their income. And what I think is likely is that number is probably 80, 85% when immigration status isn't in consideration. So I think we're too early into the process now to know, but I think when you take away the barrier of immigration status in California, that's probably a much higher number. You can find out if your clients are on Medi-Cal by looking in HMIS, and if providers have, when they've met with clients, taken a picture of their Medi-Cal card or put down in the notes or in parts of, I don't know if your HMIS has a section where people are entering the Medi-Cal data, but that's a really good place to start to see if one of your fellow service providers in some other interaction with your client has already entered that information to HMIS. You can ask the client if they have a Medi-Cal card. They may or they may not. We know they're challenging to keep documentation with you as you are experiencing homelessness, but they may. You can also ask them if they have a managed care plan, and you know your managed care plan here in San Mateo, so you can ask, you know, have you ever heard of San Mateo Healthcare Plan? And they may know the name of the healthcare plan, but they might not know what their Medi-Cal number is or what their card is. And you can also, with your client with you, call the county Medi-Cal office and just tell them their information and ask for, you know, can you help us? Give us their Medi-Cal number, give us their Medi-Cal card. They won't let you do that without the client with you. So that's important, unless you have a special status where you can act as an authorized representative. But most folks working in the homeless system don't have that. I think that is the basics on Medi-Cal. Am I right, Carla? Yeah. So I just want to stop because that was a lot of information. Some of you might have known a lot of that information. Some of this is really new to you. So just want to make sure that everyone who has any clarifying questions, this is the moment to put it in chat. Come off mute, raise your hand. Were people aware of the immigration status change? Thumbs up if you were aware, or yeah. Kind of a big deal, I think, for a lot of our clients who have never been able to get access to healthcare before. Okay. Well, we'll have more time for questions later, but we can go to the next slide. And I think that's you, Carla, yes?
Yes, thank you. So just to let folks know, after this section, we'll have our 5-minute break. So I know it's just nice to know when to expect that. So yeah, I'm going to be talking about CalAIM, and my dog fell asleep on one of my hands, so now I have to try to squint to see things from my screen from where I'm sitting. So if you see me squinting, that is why. But first, I'll start with an overview. And for folks who maybe joined a little bit later and didn't hear us say this, like we're happy to be interrupted if you have any questions or need any points of clarification. So please feel free to stop me and we're right in the chat, interrupt anything you'd like to get that information you need. So CalAIM. So CalAIM stands for California Advancing and Innovating Medi-Cal, and CalAIM is basically California's new Medi-Cal initiative. It's what they call a 1115 waiver, sorry, which essentially is when a state requests to basically pilot or try different programs, different ways of like Medi-Cal, Medicaid programs. And so this one that California is doing, CalAIM, is focused on improving the health of Californians with the most complex needs. And it's a pretty new program. It started in 2022, and it covers a range of issues and populations. We've got like the housing related services, which we're gonna spend more time on because of the population that you all serve. So that includes like the enhanced care management and community supports. But we wanted to note that CalAIM also covers behavioral health expansion, criminal legal system transitions, and a few other sort of issues that are going to impact, you know, some folks experiencing homelessness, and then also other folks too. And so, yeah, people experiencing homelessness who have physical or behavioral health issues are one of the populations of focus of CalAIM. So CalAIM and people experiencing homelessness. CalAIM includes these two programs that are listed here on this slide that offer benefits and services for folks experiencing or are at risk of homelessness. So enhanced care management, which we often refer to as ECM. All managed care plans have to provide ECM or enhanced care management to their eligible members. But then community supports, the managed care plans are encouraged to provide those services and to offer them, but it's not required for them to do so. And there's different types of community support. So some managed care plans in different communities offer, you know, maybe 9 out of the 14. In some communities, they might offer 2 out of the 14. So it really depends community to community. But we'll go into San Mateo specific information when it comes to the community supports. So you all kind of know what's available to your clients in your community. And yeah, as noted here, most are starting with some, and they can also add those community supports over time. And so we can talk about that too. So first, starting with enhanced care management. So eligible populations to receive this service include individuals and families experiencing homelessness. And essentially, enhanced care management is this intensive care coordination in services across multiple systems of care to help address basically all the needs that a Medi-Cal member might have. And so an ECM care manager, for example, can help Medi-Cal members set clear goals. They can make sure that they really receive the full array of benefits that they're eligible for. And then they're also going to play like a huge coordinator role across systems to help their members achieve those goals and get access to the services that they need. Also notable is that ECM providers are required to meet their members where they are in their communities instead of just at the doctor's office. So they, you know, need to meet them at shelters, on the street, or in their home. And this program is like fairly new. Like we said, CalAIM initiated in 2022, and it can be effective, especially when ECM providers have connections to the homeless system of care and really understand how to serve this population. And when an ECM provider does have that experience and knowledge of serving folks experiencing homelessness, then they're really able to serve folks most effectively, right? And what we're finding as this program is sort of rolling out in different communities or being like implemented in different communities is that in some communities, some of the contracted providers of enhanced care management services are sometimes located out of state and might not have a connection to the COC. And so that really limits their ability to find people, for example, when they need to, and to really serve folks most effectively. So we're sort of seeing basically across the state different levels of impact for the people who are actually being enrolled in these services and who are receiving these services. So just like something, you know, to be noted is that if you're a homeless service provider and you're not already an enhanced care management organization, but you're considering it, that could really make a difference for the folks who are receiving these services, because you are more than likely very experienced in serving folks who are unhoused or experiencing housing instability, and you know your community, right? And so that could really make an impact. And then just wanted to like share some of the things that the Health Plan of San Mateo kind of states on their website about ECM providers of what they can offer. So they can find doctors and get appointments for health-related services that a person might need. They can help somebody better understand and keep track of their medications. They can set up rides to and from healthcare visits. They can find and apply for community-based services based on somebody's needs. So this includes like housing supports or even meals to fit a person's health needs. And they can also help a person get follow-up care after they leave the hospital. So they can really provide a lot of different supports for the folks that you are serving. And then we move into community supports. And so, like we mentioned, this is part of like the new services that MCPs can add to the package of services that they offer to their members. Like we mentioned before, community supports, like the health plans are not required to provide community supports. And then they can provide the community supports that they want to. So like we said, not all health plans are offering all of them, but many of them are offering most and are continuing to roll out new ones. So on this slide, what we did is we highlighted in red and bold the red font is the housing related community supports that the Health Plan of San Mateo offers according to their website. So they offer 3 out of the 4 that we would consider like the very core like housing related services. So they offer housing transition navigation services, they offer the housing tenancy and sustaining services, and they offer the housing deposits. One of the ones that are housing related community supports that they don't offer, according to their website, is the shorter term post-hospitalization housing, which kind of sounds like a big need in your community, because we've mentioned it, you know, folks just not having a place to be able to go to when they have the need to recover after a procedure or after they've been hospitalized, right? So a huge need in the community, and you know, it's not to say that the health plan is not going to roll that out in the future. They may. And then the other bolded community supports on this slide are the other ones that the Health Plan of San Mateo also offers, but that we don't necessarily consider like the housing related community supports, but they're still extremely important and you know, very like critical and might be needed by your clients. And so when we're talking about who's eligible for community supports, adult members are eligible for community supports if they're a Health Plan of San Mateo, Medi-Cal, or Care Advantage member. They have a care manager who's going to help work with them to reach their goals, and they're willing to receive these services. Now, a little bit about like the differences between enhanced care management and community supports. ECM, or the enhanced care management, that's focused on certain subpopulations, right? And one of those populations is folks who are experiencing homelessness. With community supports, each community support services has eligibility requirements. So each of these supports are intended to serve people in different situations. And so at the bottom here, it's kind of small, but there's a link to a DHCS community supports policy guide, where if you click on that, it goes more into depth about like who's eligible for each community supports and what each community supports really is and what services they include. Um,
I'm going to come off mute and just say that Home Base has simplified those a little bit for the 4 housing related services. And I'm going to put our toolkit and our fact sheet on that specifically in the chat. And that basically is just a simplified version on the housing related ones.
Thank you so much, Julie. It's a really great resource. And it's the audience is for COCs, so it's very much like trying to break it down. And we can include that link to, I think it's actually linked in this PowerPoint. So when you all receive the PowerPoint, you should be able to click on the link and access that resource as well. And then according to the Health Plan of San Mateo, how are members told that they're in community supports? They get a letter from the plan saying that they are eligible. But if, if a member wants community supports, they can actually call member services and find out if they're eligible and get connected to those. So you can definitely help refer folks. And there's referral forms that providers can fill out with their clients to help them get referred to these services. Because like we said, many folks who are experiencing homelessness don't have mailing addresses, so they might not ever get that letter, right, from saying that they're eligible for these services. So definitely something to look into. So now we have our second Zoom poll. We'd like to know, have you ever referred a program participant to enhanced care management and or community supports? We'd love to know if you've done that before. Thanks, Sarah or Julie. So I'll wait like a minute or two. And also one of the choices is my organization is a contracted enhanced care management and or community supports provider. So we'd love to know too if we have any folks who are on the call who know that their organization is actually contracting with a managed care plan to provide these services. Wait about 30 more seconds or so. Awesome. I'm going to go ahead and end the poll and share the results. So it looks like about 57% of folks, a little over half, said they've never referred a program participant to those services. About one person said they have, and then 2 folks said they're not familiar with those programs or services. So I'm really glad that you all are here today, and hopefully, that'll be something that you might refer to or help just bring awareness to the folks that you're serving about these services and the fact that they might be eligible to receive them. So.
Carla, is it okay to spend a few minutes just talking about we're about to go into the break, right?
No, there's I think a few more slides. So we're going to talk about how to refer folks.
Awesome. Okay.
And then a reflection. Yeah. You sure? Okay. All right. So, but we're almost there, y'all. So almost to the break. So referral processes. So sometimes this doesn't seem to be the case in San Mateo, but for folks who have referred somebody to these services, please let me know if I'm misspeaking here. So referral processes can be a little bit confusing for these programs. And sometimes if you have more than one health plan in a county or in a community, they can sometimes have different referral forms. And so it can get a little bit confusing. But the good thing is that Medi-Cal members really who are eligible for these services can really be referred by anyone to these services. So they can refer themselves, you can refer them, they're a community member, a family member can refer them. So it's really great to have that, right? And then, a person has to be enrolled in Medi-Cal first. So if you're like trying to get your client connected to ECM or CS or both, and you're like, you find out that they're not enrolled in Medi-Cal, so that would be the first step, is to go ahead and to get them enrolled. And then once they've selected a managed care plan, or they were put in a managed care plan, then you're going to be able to apply or refer them to these services. And then once the member is approved and enrolled, the managed care plans, they contract with different providers for enhanced care management and community supports. Members who are enrolled in both may or may not have the same provider for both, so that can get a little bit confusing as well. If a person is enrolled in ECM, their ECM provider can and should assess and refer them to the appropriate community support. So hopefully that ECM care manager is really coordinating in that way. And so, just some, let's see. On the San Mateo Health Plan website, it does say, that, they can enroll folks who qualify for ECM based on their member health records, and then members who want to enroll in ECM can actually call their member services. And then if they're not eligible, then the health plan will help them find other support. So if you're kind of in doubt if somebody would, be eligible for a community support, they should be eligible for ECM. If they're experiencing homelessness, they will be eligible. But if you have any doubts, it's better to just refer folks than not refer, to call member services to just double check. All right. And then Julie, did you want to touch on, I have in my notes, I know we sometimes talk about some of the set of challenges that folks are facing. I don't know if folks have any challenges that they do want to share about accessing ECM or CS, because it sounds like folks, the majority of folks here haven't referred their clients, but we could take a minute if folks want to share. Have you had any challenges with accessing ECM or CS? Love to hear that.
Carla, I was thinking it might be useful for us to kind of talk through as a group, since it's such a small group, take a few minutes to really talk about you haven't been doing this yet, a lot of you. So just kind of talking through, this could be something that could really be helpful to your clients for a couple of reasons. First of all, experiencing homelessness, they often don't go to their doctor because if they're living unsheltered, they don't want to leave their belongings at the encampment. They might not be able to bring their pet to an appointment. And so they're not getting any care management. They may not be taking their medications. The care manager for ECM can go to the encampment or visit them at the shelter and help them get the services that they need, remind them about what they need to do to take their medications. So it's really, really, really valuable, that hasn't existed before. And I think confidently, probably most people experiencing homelessness could really benefit from this. And especially if those ECM providers are connected to you all. Either you all are the ECM providers, or the ECM provider that isn't your organization or familiar knows about you all and is connecting with you and partnering with you to help kind of do together hold your clients, or that when you have something that you can't do, but maybe the ECM provider can do for them. So really want to say, exercise that muscle and try to refer some of your clients to ECM, with their permission, of course, but just say there's this new benefit, you have Medi-Cal, you don't have to worry about, you can see a case manager at the shelter, you don't have to leave all your stuff behind at the encampment. They can come meet with you, etc. So that's something really just to think about and hold, and take maybe in the next 6 weeks after you leave this meeting, give yourself a challenge. If you can maybe refer 1 or 2 of your clients, try seeing 1 of your 2 clients to that. And then community supports, you notice that those 3 community supports Housing navigation, that sounds familiar. Housing tenancy and supporting sustaining services, that sounds familiar. Housing deposits. These are services that often you all as COC members are providing. If your client is under Medi-Cal, they're eligible to get that and Medi-Cal will pay for it. And the COC doesn't have to pay for that. So it has benefits not only in getting Medi-Cal members these services they need, and they, in some ways, like the tenancy and supporting services can be long-term. They aren't necessarily as short as maybe the COC funding can provide. But also, they are ones that for your COC, like if you have Medi-Cal members that you're doing housing navigation for, and you're having to have a wait list because you don't have enough money for enough housing navigation for everyone in the COC, if some of those Medi-Cal members are getting it through the Medi-Cal benefit, that frees you up as a COC to leverage those resources more for those who aren't on Medi-Cal. So these are really like, it's kind of revolutionary that the healthcare system, it's an entitlement program. It's not like housing, where the reason we have VI SPDAD and we have the prioritization list is because there's not enough services and programs to go around. And so we have to have waiting lists. That's not the case for Medi-Cal. If you're eligible, you're entitled. You don't have to wait. So thinking of that, like when we can't give everybody our housing navigation services because we only have so much funding, if the Medi-Cal folks can get it through their Medi-Cal managed care plan, they won't have to go on a waiting list. So just wanted to like really bring home, these are really, really, really like added significance to serving people experiencing homelessness that 2 years ago, we never had these opportunities. So I'm happy to take questions about that or scenarios that you want to ask. Would this be possible? Would that be possible? Okay, well, think about it and interrupt us later if you have ideas or drop them in the chat. But again, the challenge is maybe one client referring to one of these in the next month, month and a half.
Thanks, Julie. Since we're about like halfway or a little over halfway, I want to give us the opportunity for everyone to kind of get a break, stretch, step away from the computer, use the restroom. So I'm going to go ahead and start my timer. So we'll come back in 5 minutes or around like 2:15. So yeah, see you all soon. Please don't leave.
So, are you gonna remember this if I tell you?
Maybe an address or what?
Yeah, so the time frame of when you were here.
Yeah.
Because they're gonna ask you.
Yeah.
I'm sorry if that beep startled anyone. I don't know if anyone else heard it, but I was using the little Zoom app timer. So yeah, we'll get started in a second or two. Just gonna let folks sit back down, get settled again. Hopefully you got to breathe some fresh air, get a drink of water, get a nice stretch in too. All right, let me start sharing my screen again. So this is sort of where we left off, sort of the ending of this portion of CalAIM. So I just wanted to bring to your attention this resource slide. So like I said, when you share when the slides are sent to you, you'll be able to click on all of these links. And a lot of these are sort of, Julie had shared one of them in the chat, but these are like tools that Homebase created that are really, the audience is COC and homeless service providers, to be able to break down some of like CalAIM and its different services and programs, so that you all can really maximize and leverage them for your clients. So hopefully they're helpful to you. So next, we're going to do just a little quick reflection again, just to sort of wrap up this section. So if you could take about a minute or so to just write down a couple things that you learned about Medi-Cal and CalAIM that maybe you're hoping to take back to apply in San Mateo or with the clients that you serve. It can be, you know, things that hopefully you learned today for the first time, or maybe something that, you know, you're thinking about implementing now that you sort of heard us talk about this. So it'll take about a minute for this. Awesome, perfect. So then we're going to go back in our little rapid breakout rooms and just, oh, sorry. Actually, this one we're sharing in the chat. I totally forgot about that. So if you all could just share in the chat how you might like sort of apply the new information in your community. So some of the things that you hope to take back and that you applied. Would love to see it in the chat, or if you'd like to come off of mute, that would be amazing as well. So we'll give folks a minute or two to type or to come off mute.
Is anyone gonna go read our materials or refer a client to CalAIM, one of the two benefits, ECM or CS? Go talk about it with your coworkers, let them know about it. Just trying to think of all the high level stuff you could do.
I know it's a Friday afternoon and it's tough, but does anyone want to come off of mute and just mentioned something that they might do. Keith said, covers navigation, deposits, and care where the client is. So something that Keith like learned about Medi-Cal and Cal-AIM today. So that's great. Thanks, Keith. Was anyone really like super surprised by any of the information that we shared? Angelica said, I'm going to connect more clients that are undocumented with health services, knowing that they can apply to it. That's huge, Angelica. Thank you for sharing that. Yeah, I find, and you all know this doing this work too, it's like a lot of it is just telling people about the things that they're eligible for, right? Like sharing that information. Alondra, I hope I said that name right, said, I learned the housing support after hospitalization. I learned about the housing support after hospitalization. This will be great to explore for elderly participants. Another is the community supports for housing. It's always good to know other options to help keep participants housed. Awesome.
I
Yeah.
do want to say one
Oh.
specific thing, for the support after hospitalization, that's one of the benefits that San Mateo Health Plan doesn't offer. But currently, right, so, but that might be a really good sort of advocacy piece on your end, is to say, hey, you have some clients who would really benefit from that. Are they thinking about adding it? If so, when? If they aren't, you would really encourage them to. But just to be very clear that that's one that most other managed care plans are providing, but not in San Mateo as of yet.
Yeah, I second that advocacy piece, and even you know, just going to, not just going to your COC, because this can really be a impactful thing, but going to your COC and saying like, hey, like this is a need that we've observed. Like, to what extent are you, you know, discussing with the managed care plan that, you know, of figuring out how to like make these services available? Because I know in some communities that I work in, it's been a talk with like the county and like one of the bigger cities in the county to say, okay, like maybe some of your non-congregate shelter options, a percentage of those beds at certain shelter locations can be reserved for post-hospitalization, for that short-term post-hospitalization community support service, right? So it's really like connecting the dots and having those conversations to see where that can be possible in the system that exists in your community, right? It doesn't have to be a new shelter bed. It can be existing shelter beds. It can be existing services that are, you know, reserved for folks who need that type of service and paid for with Medi-Cal. And I'm glad that you mentioned also, Alondra, like elderly folks too, right? That's huge. Well, thank you all for sharing. I appreciate that. Thanks for sticking with us on this Friday afternoon. And then we already had our break, so I'm skipping that slide. And then I'm going to pass it to Julie to talk about Medi-Cal renewals, which is another great area to do advocacy in here for your clients.
Thanks, Carla. So I think we can go to the first slide. And before we get into this, we want to hear from you all when it comes to Medi-Cal renewals, what you've been doing. So if Sarah, you can put up the poll, or Carla, if you can put up the poll, we'll get your pulse on what you all have been doing around Medi-Cal renewals. Thank you. We're really looking to know, have you helped people renew? Have you had to help people who've lost their coverage? Have you helped participants use your organization's mailing address to be able to receive their mail from Medi-Cal? Do you have knowledge about what to do when someone loses coverage? And or knowledge about how to help people appeal the coverage if they lost it? We'll keep it up for a few. The Friday afternoon days is it's clearly happening. We'll keep on going though. So we'll give it a few more minutes, a minute or so more to see if anyone else has had experience with this. Okay. Well, it seems like we didn't give, I haven't had experience, so that may be part of the results are skewed a little bit, but for those of you who have helped, about half of them have helped people renew, and then the other half has, a little more than half has helped people when they lost coverage. I'm going to just assume for purposes of this conversation that those of you who didn't respond maybe haven't had experience with renewals. So we'll go ahead and do this, and hopefully those of you who have had experience benefit from a little bit, we maybe provide a little bit more detailed information. So we'll go ahead and dive into the first slide. And this is our conundrum that we've been faced. What if your access to healthcare was dependent on receiving a piece of mail and you don't have a stable mailing address? And that's really what you all know. That's something that is a challenge for almost all our clients, and particularly a challenge when it comes to making sure people have access to the healthcare coverage and services that you need. And in particular, this last 12 months has been a real challenging thing because of a policy change that happened. So we'll go ahead to skip to the next slide. So for 3 years during COVID, during the state of emergency, public health emergency during COVID, people did not have to reapply or renew their Medi-Cal. They just assumed that anyone who needed it, and they didn't have to prove that they're income eligible still or their family size was the right size, et cetera, et cetera. And then when the public health emergency lifted last year in April or May, all of a sudden people who hadn't had to renew for 3 years had to renew. And that also happened in California. And what they predicted back last year was that about 2 to 3 million people in California were going to lose that coverage, and over half of them were likely still eligible. And as you all know, and as all the information we've been talking about so far today, is how important health coverage is to addressing homelessness. It's really key to addressing homelessness. And we all know that having stable housing has a huge impact on people's health. So given both of those things, that makes renewing Medi-Cal really important. And the other really important thing is that the policy, as we found it last year, was that Medi-Cal was sending everybody their renewal notices in regular mail, and many, many people experiencing homelessness were not receiving it. And many people who were homeless during those 2 or 3 years who had then landed in stable housing may not have updated, so they didn't have the correct address. So they were eligible, they were housed, but they weren't getting that renewal notice because it was being sent to the last known address, which was, 2, 3 years ago. So maybe they were homeless, they didn't get it, or their address had changed. So a lot of folks that we all serve were not aware of the need to renew. And they're going to lose all those benefits, those great benefits that we just talked about. So there's automatic renewals and manual renewals. And this picture is what the mail looks like. They were really, it was a really rigorous and important campaign. They put everything in yellow envelopes. They wanted to make sure everybody saw it, got it, was obvious, but not helpful in a yellow envelope if there's no address. But basically they had the ability to renew members without having to have them give any information. They don't have to do anything. The system, they look at data in the system and they automatically renew people, or they can manually, and people have to fill out the paperwork that comes in this yellow envelope, show any proof of anything that they need that might have changed. send it in the mail. And that was going to be really onerous for people experiencing homelessness. So next slide, California recognized this and got a federal waiver for people very low income or who have fixed income or who have no income. They don't necessarily need to complete a renewal packet. They are being automatically renewed based on the information that Medi-Cal already has about them, which has really been a boon. This started as of October 1st. And the data, I think September 1st, maybe, the data of those folks just came out for December. And the automatic renewal rate before this new policy went into effect was about 33% of people who are eligible each month to be renewed were being renewed automatically. And it's about 1.5 million people a month. So 33% is not a lot. But once this policy went into effect and they could see that effect, the first month was December, it was 66% were automatically renewed. That meant those people, didn't matter that they didn't get that envelope, because if they were low income, had a fixed income or no income, they were being automatically renewed. And so we're really seeing, and also what that meant was less people were being discontinued from Medi-Cal. This month it came out 60% for January, and they're guesstimating right now 62% in February. So these are real numbers from this one policy, which is just kind of a big deal. But not everybody experiencing homelessness income is well founded in their Medi-Cal files at the county. And so if they aren't clearly low income or fixed income or zero income, they may not be getting that automatic renewal. So for those folks, there's two things you can do. The biggest and most important thing you can do is you can have your client call Medi-Cal, call the county, call CalFresh, anywhere in the county. When the county hears this person is experiencing homelessness, it's considered a quote unquote change of circumstance, and the county can extend their renewal by 12 months. So I'm going to just walk through this really carefully. I renewed in June of last year. I mean, I applied for Medi-Cal and got approved in June 2018. So my renewal date is June, but it's March right now. I'm experiencing homelessness. If I call this county and tell them I'm experiencing homelessness, or you and I call the county on my behalf, and we tell them today, March 15th, I'm experiencing homelessness, I won't have to renew in June. They will give me another 12 months before I have to renew. So the next time I have to renew will be March 15th, 2025. So that's something you can help with your client. If they're not eligible right now in their re-enrollment period right now, you can get them an extra 12 months before they have to renew. And that's called a change of circumstance. And it's whenever the county public benefit programs know that that person is experiencing homelessness. So that's something really important that you could do on behalf of your clients. Next slide. So there are also, for those folks who aren't getting automatically renewed and who you can't call, or it doesn't work when you call the county, there are a number of ways you can help them renew. You can find out when their renewal date is by looking at their online account at Benefits Cal. You have to do that usually with them unless you have your own community-based account. You can identify, provide a mailing address that is at your site so that they have a place to receive their Medi-Cal mail. You can help them by referring them to a health enrollment navigator. Every county has a list of health enrollment navigators. And when you get this, you'll be able to click on the links to find out who the health enrollment navigators are in San Mateo County. So there's a lot of ways you can help people renew. But again, if they're not in their renewal period right now, all your clients who are on Medi-Cal who are experiencing homelessness can get an extra 12 months if you call, or they should be able to. And if they don't, let us know it's not working. Next slide, Carla. So here, when you get this, you'll see we have created obviously we think these things are really important because we have two toolkits that have come out in the last year and a half. One was on helping people understand CalAIM and enrolling in those benefits. And the other was helping how to renew clients for Medi-Cal. And those materials have some tips and tricks, an easy place to find out where your Medi-Cal offices are in San Mateo, any health enrollment navigators that can help your clients so that you don't have to, how to get free advice and legal services if they're having a problem, either they lost their Medi-Cal and they're having a problem appealing or renewing, and then the renewal site at DHCS. So we wanted to share that because losing healthcare coverage is awful for our clients, whether there are housing related benefits or not. But now that there are housing related benefits, it's even more important, because if they're getting community supports or they're getting ECM and they lose their Medi-Cal, they're losing access to those housing related supports as well. So it's really important to make sure clients who are getting housing related services don't lose their health coverage. So we just want to throw that in to just like make that connection of how more important it is now than ever. And I think next slide is for you, Carla.
Thanks, Julie. So great information about Medi-Cal renewals. I want to just like pause. Do folks have any questions about what Julie just shared about Medi-Cal renewals? All right. So in our last 25 minutes together, we're going to talk about some other forms of healthcare delivery for folks experiencing homelessness, and sort of wanted to weave into like the bias that we talked about before. Street medicine programs, which we're going to talk about, as well as some other programs that we're also going to talk about that serve folks who are experiencing homelessness. They can really be really effective in serving folks who are unhoused, because they're really meeting people where they are. A lot of the times, these providers are physically, like I said, meeting people where they are, and then are prescribing medications and treatments and treating conditions with the context that the person like lives in, right, every day, which is really important. And that understanding of like the things that people face when they're, especially like unsheltered, is really important in that healthcare delivery. So we wanted to highlight these programs. So street medicine, maybe this is something that you all are very familiar with, but street medicine is also called backpack medicine. So this is the delivery of medical care directly to people who are unsheltered or living outside, including encampments, but not limited to encampments. And street medicine providers really do go where people are. They go outdoors, they go in their cars, they go in encampments, and they offer the medical services on site. So that's sort of what sets street medicine programs aside from like a street outreach team who maybe is going out and, educating somebody about healthcare services or referring them. Like the street medicine folks, like team, can really provide those medical services right then and there. And then, they can also help connect folks to other medical care services, as well as the housing resources. And they're really helpful and important for trust and relationship building, in addition to addressing people's immediate health needs. So just a little bit about street medicine. Street medicine, it was traditionally offered by health clinics or hospitals, like brick and mortar sites, but we see them embedded in other types of organizations as well in California. And then starting at the end of 2022, California street medicine providers actually were able to start billing Medi-Cal without being part of a physical location. So even an individual physician could go out and then actually bill at a new place of service, right? So it's called a new place of service code. And that, really was significant for street medicine providers to be able to bill Medi-Cal for those services when they're meeting people where they're at. And enhanced care management and community health worker Medi-Cal benefits are great resources for street medicine programs who are looking for different funding sources. the San Mateo home base team shared that that San Mateo does have a street medicine team. So Life Moves has a local partnership with a nurse practitioner and a therapist that go out 4 days a week. And so you all might be familiar with that program. So wanted to just like elevate that you all have that. And that's an awesome, awesome resource to have for folks who are experiencing homelessness in your community. And also just to mention that, like, so, you know, the way that San Mateo street medicine program is set up could look really different and does look really different than other communities across California in how their street medicine program, if they have one, looks. So there's different compositions of staff. There's different, like I said, they can be embedded in different types of organizations. And so they all look very different. So then some similar healthcare programs that also are valuable resources for folks experiencing homelessness are the mobile clinics, mobile medicine. They still prevent people from having to go to a physical building to receive care. So you're asking folks to step inside a vehicle in a mobile clinic. They can get closer to where folks who are unhoused are living, but it does still require people to leave their exact location to get to the mobile site. So people have to enter the mobile clinic, right, rather than being provided care literally in their own environment. And as you all know, that can really create some challenges for folks and can be a barrier because a lot of folks don't want to leave their possessions behind. They don't want to leave their pets behind. And so that can be a barrier to accessing that care. Most commonly, they provide wound and other acute care and basic medicine administration. And then the street and mobile medicine teams can include like psychiatric assessments, care delivery, so both mental health care and substance use services, write prescriptions or dispense medications. We see a lot of like chronic disease management as well with street medicine programs, which when I mentioned earlier, we were talking about sort of the high rates of chronic illness amongst folks who are unhoused. That chronic disease management can be really, really big, right? And can be really important and critical for somebody's, while somebody's waiting to be housed. So just some strategies to connect unhoused residents to care. So asking healthcare providers to join street outreach teams to visit encampments, and keeping in mind that, you know, medical doctors, MDs are not the only providers. There's psychiatrists, there's nurse practitioners like you all have in your street medicine program. There's PAs or physician assistants, registered nurses, and others who can still help provide care and can prescribe medications a lot of the times too. Medical and nursing schools and teaching hospitals could be interested in creating student programs. So sometimes street medicine programs are, for example, embedded into universities, and there's students that go out there as part of the care team. And then enhanced care managers and community health workers may also be good options of health system partners to include in outreach as well. So as part of your street outreach teams. And then continuing, like just talking about strategies to connect folks to care, working with local providers to set aside specific days and blocks of time where encampment residents can walk in without appointments. That can be super helpful. So maybe providing transportation support and measures to ensure that people can safely like leave their homes and belongings. So maybe like storage for the day and other things like that. Partnering with pharmacies to help simplify the process for prescriptions and medication access is also a big thing as well. Accompanying clients to health appointments to support them during and after the appointment. So this is sort of where we covered that bias section, like how to be somebody's advocate, how to recognize the experience that they might have, might not be positive, but is really critical to building that trust so that they can, you know, still continue to feel comfortable to access healthcare. Helping manage people's prescription and recommended course of treatment, which is something that we mentioned, the enhanced care management care manager. If your client is connected to those services, they can help your client actually manage those prescriptions and their recommended course of treatment too, which is huge. And then also tracking follow-up appointments is really helpful for folks as well. So here are just some resources. So we linked the Health Plan of San Mateo's CalAIM page where they include a list of the enhanced care management contracted providers that they have, as well as the community supports providers that they contract with. They have information about who is eligible and how to access that care. They also have their referral forms on there. So it's a very good informative webpage. And that's not the case with all the managed care plans website. So that was nice to see. We also then have the Homebase CalAIM Basics Toolkit, which Julie shared. I just realized that we need to add a link in there about San Mateo's street medicine team, so we'll add that. We also added just the California Street Medicine Landscape Surveying Report from USC and CHCF, in case you were interested in reading about what street medicine programs look across the state. They did an amazing report that kind of talks about the composition of staff on the different teams and how much time staff dedicate to that, and sort of what services folks offer. So really interesting if you're interested in digging into that. We also have a link to the San Mateo Behavioral Health and Recovery Services website and the San Mateo Public Health Department as well. So just sort of all the links to for you to connect with the healthcare system in your community. And then we're just going to kind of be ending with a reflection. So we're hoping that you can take a minute to write down any questions you might have about the information that you received, not just for the section that I just went over, but for the entire training. One change that you plan to implement in your work, and then one thing you hope to bring back to your organization. So we'll take a minute for you all to do that. And then we'll ask you to come off mute or share in the chat your questions and share what you will take back to your community. So we'll give you all a minute and then we will close this off. So, but please don't leave just yet. All right. Does anyone want to come off mute and be brave and share maybe one change that you hope to implement in your work, or one thing you hope to bring back to your organization, or maybe even a question that you have? Does anyone want to come off mute and share? Or share in the chat. That's always an option as well.
Hi, I just want to know what is the best way, the best way to help one of our clients that he has his medical services in another county, and it's here, and we are trying to make the call. We are trying to change, the area, but it's not working. What is the best way to do that? Like if he's in another county and we need to change it to San Mateo County.
Yeah, Julie, do you want to answer that one?
Yeah, so I think we said it early in the beginning, and we can get you a link to their phone number. But across the state, there are legal services offices that will help people with complicated situations. And unfortunately, having Medicaid in one county and moving to another county is one of those ones where sometimes it's helpful. to have the Health Consumer Alliance, you can call them yourself and they might be able to advise you. They do a lot of advice over the phone. And then if they can't advise you or they advise you and it's not helping, you can call them back and they can provide free legal representation to help solve it. So let me go get their phone number for you and I'll put it in the chat.
Thanks, Julie. Yeah, the Health Consumer Alliance is a wonderful resource. If you haven't utilized them or haven't heard of them, they're great. Thanks for the question, Angelica. Anyone else have a question or want to share something that a change you'd implement in your work or one thing you're hoping to bring back to your organization? Any thoughts?
I'm putting this in the chat. One of the best things about this is they have all languages available. So if you call and your client wants to talk with them directly and your client uses any of the threshold languages other than English, they should be able to get assistance from them. So that's really, I didn't know that till yesterday, so or Wednesday. So I'm really excited. And like I said, they're all over the state. I can also post here the direct one for San Mateo. But sometimes that 800 number is, or the 888 number is all you need, and they can give you a really quick answer. Especially if you tell them what the other county is, they might be able to help really easily. But I'm going to put in the San Mateo Health Consumer Alliance also here. There you go.
Thank you. It looks like in the chat, Violetta, and I hope I'm pronouncing it correctly, said, I have a senior couple who's losing full benefits at the end of this month and will be switched to a share of cost because someone is receiving SDI benefits under senior social security number fraud. Any suggestions on how to help?
Oh, absolutely. That Health Consumer Alliance. They will do legal representation for that couple. So yeah, I would call them this afternoon as soon as you hang up. Great. Yeah, they are a huge resource. So when you think of legal services and legal aid, often you think of low-income people. And when you think of homeless people, often they're low income, but Health Consumer Alliance will help on healthcare issues regardless of income. So they're funded with additional funding through different agencies that are in California that implement healthcare coverage. And they all have said, we want it's much better to help people regardless of income stay on coverage. The Health Consumer Alliance solves these problems in really fluid and seamless ways. So regardless of income, so it doesn't matter what their income is, they can get assistance from them.
Anyone else have any questions coming to mind, reflections, feedback, criticism, compliments? I'm just kidding. All right. Well, it seems like folks are pretty quiet now. So we do have a feedback survey Zoom poll. If Sarah could launch that for us. We'd love to hear like how helpful you think that this training was. It really, really does help us. Like, please be, please be honest and provide your feedback and take that time so that we can deliver even better training next time to you all. And while the feedback poll is open and while you all are taking the time to fill it out, we're also happy to answer questions too. So just keeping that in mind. And while you're doing that, also wanted to share an upcoming training happening in San Mateo for serving clients with criminal records. It's happening Wednesday, April 3rd from 1 to 3. And that's Homebase's Criminal Legal System Initiative who's providing this like 2-part mini series, and there's a registration link there. that I can actually pop into the chat. Maybe, or maybe Sarah has it. And you can always contact San Mateo at homebaseccc.org to get registered. So I'll just wait a few minutes for folks to fill out that feedback survey. Yes, and then Julie posted our Medi-Cal team at home base. We can, if you have any questions about like Medi-Cal or anything that your clients are facing that you're seeing, we can always answer your questions, connect you to the right folks. So we're happy to stay in touch with you. Oh yeah, and then Sarah posted the training registration link for the training that I have up on my screen here for serving clients with criminal records. That one's on a Wednesday, so maybe the Friday slump won't feel as heavy on a Wednesday.
And it's absolutely gorgeous weather in the Bay Area right now.
Yeah. Makes
That's-
it hard to be indoors. Stop sharing my screen. Thank you all so much for being here. For those of you who like filled out the survey and maybe don't have any questions, you're free to go. Thanks for sticking with us and taking time out of your day to attend this training. And yeah, I hope you all your weekends are exactly what you need them to be. So thank you.
Thank you so much.
Thank you, Angelica.
Thank you, Carla and Julie. That was fantastic.
Thank you, team.